All right. So this is a 87-year-old male that comes in with NYHA3 heart failure symptoms due to severe mitral regurgitation, aortic valve regurgitation, atrial fibrillation. In October 2015, he had AVR with a 25-millimeter Magna Ease valve, mitral valve repair with a 36-millimeter Edwards Physio 2 annuloplasty ring, and closure of the anterolateral commissure, Cox-Maze-4 procedure, LAA ligation, and repair of ascending aorta with a felt wrap. He was found to have subsequent anterolateral commissure failure, followed by severe symptomatic mitral regurgitation. And because of his age, prior sternotomy, and also felt wrap procedure, felt to be prohibitive risk for repeat surgery and was referred for percutaneous mitral valve repair. And this is a tough case in the sense that this patient has a prior ring in place, as well as also has this very lateral severe mitral regurgitation, very hard to image, very severe wraparound jet, and a very small posterior leaflet in this region. And if we can see here, you can see how much of an eccentric jet this is, how much of a wraparound area is involved. And on the three-dimensional view, it's just very hard to even localize where this is coming from. And when we get down to it, you can see the length of the posterior leaflet over here in terms of its relation to the anterior leaflet. So we went from a mitral clip approach because this was what was available to us at the time, and we also felt that the patient was not going to be a great candidate for transcatheter mitral valve replacement due to LVOT issues. And this was a lateral placement of the clip and grasp, mild leak, and a 6-millimeter mercury gradient. And so we thought to ourselves, wow, this was much more straightforward than we thought. But that wouldn't qualify for a case at this conference, so we had to do something different. And that different was that within a few minutes, we were found that we had single leaflet device attachment, which was seen in echo and fluoro, recurrence of severe mitral regurgitation, and the gradient of now 3 millimeters of mercury. And what's challenging here is now we've changed one problem for another, right? We went from having a 3-4 millimeter posterior leaflet to now a 0 millimeter posterior leaflet in this range. And so now we have to think to ourselves, where are we going? What do we do from here? And we kind of went back to our films and said, we have a second clip, we should really try something different. And we thought to ourselves, well, if we went from a different angle and instead of using the old approach of a much more straight up and down approach, but went from a sideways approach, could we grasp more leaflet horizontally as opposed to straight up and down? And that's kind of what we end up doing, is that we end up with the angulated approach, a very lateral insertion of a clip, and we thought we had a better grasp at this point. However, we were worried that we would go from one SLDA now to two SLDAs, because just because we thought we had grasped leaflet didn't mean we necessarily did. We may have chords, this may not be more stable, and we would just be stuck at this point. So at this point, we did some fanciful catheter manipulations of a different type, and that's purposeful rotation of the clip in Chordae. And this was just taking the guide and just turning it. And we turned it once, turned it again, and just kept turning a few times. No actual, feasibility study of this has been recorded to date. Maybe I can talk to Paul about that later. But we kind of just did a purposeful rotation of delivery sheath and clip, kind of like spaghetti. And with that, what we actually saw, and you guys won't believe it, so I'll have to show you pictures, but a decrease in mitral regurgitation with the rotation. And you can see here with kind of pre-turn where we were at, and then as returning, what's going on here, right? And so this is a different thing than what we ever thought would work, but it seemed to work in this case. And eventually we came in then to final echo and an ASD closure. So with this purpose, what we actually did is we left the gripper line in place. We pulled the whole system out. Pulling on it showed decrease in regurgitation, movement on fluoroscopy. We removed the clip delivery system with the gripper line still intact. We stabilized it with a septal occluder device through the guide, and we cut the gripper line at the femoral vein surface below the skin. So what we had here is now, what's our discussion and conclusion? Regurgitation after ring implantation can make mitral clip very difficult. Clipping directly to the ring has been reported, but may not always be possible, especially in this very lateral position. Direct chordal clipping and rotation may be an option to bring leaflets together from below. There actually is a very interesting mitral device that's coming out that's not even looking at leaflets, but just the chordae. And stabilization and tethering can occur on atrial septum with a retained gripper line if you're really worried about this clip moving off. And in conclusion, this spaghetti technique can be an option in truly prohibitive risk patient population for such patients where leaflet length is too short for direct grasping. Thank you very much.